We report the case of a patient anticoagulated with atrial flutter, with pacemaker and history of upper gastrointestinal bleeding. It also presents elevated PSA, permanent urethral catheter, and prostate length of 300 cc. The technique used is as usual, but focus on certain steps of it. As we can notice in the endoscopic view, there is a large prostate but bilobulated, lacking a defined middle lobe. With no middle lobe, the enucleation begins with 6 o'clock incision, from bladder neck to verumontanum. At this point, we must be especially careful, because large prostates protrude below bladder trigon. A careful dissection should be made to prevent a detachment of the bladder neck. After completing the cut at 6 o'clock, the enucleation continues at the rear face of each lobe. It is carried out at 80 watts, because enucleation is equally effective and very more hemostatic. When we have undertaken a substantial advance at the rear side, we begin to enucleate the lateral side. At this point, it is important to keep enucleating the adenoma as a block, avoiding false paths created by little independent pieces of adenoma. This is the area with the greatest vessels. To succeed in the coagulation of these vessels, we reduce the laser power by decreasing just the energy, and then we fire around the bleeding vessel, not straight to it. When the whole rear and lateral faces are completely enucleated, we start to mark out the bladder neck. As you can see in the images, the laser fiber makes contact with bladder mucosa to cut it out. After the delimitation of the bladder neck, finally, we begin to the dissection of the anterior side. When we have nearly finished the anterior face, we perform a cut at 12 o'clock to separate both lobes. A useful maneuver is to exceed the midline at the time of enucleation of the anterior side, to identify the depth of cut we should make at 12 o'clock. At this point, if all steps have been followed correctly, you should be able to locate the sphincter flap clearly and cut it off easily. After cutting the flap, we only have to section the last attachments. This will leave the adenomatous tissue free in the bladder cavity. After completing the enucleation of both lobes, we conduct an hemostatic review of the whole prostatic cell. In the images you can see the correct preservation of both lobes. It is important to be patient during the morcellation time. Bulky fragments are hardly sacked by the morcellator. That forces us to maintain a risky angle that gets us very close to the trigon. The resulting prostatic cavity is very large, so we have to introduce much the nephroscope to avoid accidents. Before finishing the morcellation, we always have to check out these great cells carefully to prevent the leaving of adenoma pieces inside the patient. Finally, the entire procedure took just 2 hours, 246 grams sample was obtained, and the patient stayed at the hospital for only 2 days.